Hi, my name is Margaret Chang. I'm a senior partner at Retinal Consultants Medical Group in Sacramento, California. I am presenting at ASRS this year about the baseline characteristics associated with 15-letter loss in the Archer trial. Actually, for this Archer phase 2 trial, the primary endpoint was actually GA lesion size. So it was actually a primary endpoint there, but there were some key secondary endpoints like visual acuity, functional outcomes like low luminance visual acuity and things like that that are really important to patients, and those were actually significant. So it was basically patients who had vision loss already, but still had some vision to lose. So generally people between 2040 and 2100 were most at risk of developing 15-letter loss, as well as people who had subfoveal lesions. So subfoveal lesions were more associated with 15-letter loss than extrafoveal lesions. Age and lesion size were not associated. I mean, we thought that those would be correlated, but there weren't any other ocular or medical risk factors either that correlated with vision loss. You know, I think having a sense of who's most at risk is always helpful. So knowing that someone who's better than 20/40 is probably going to be able to preserve their vision for the next year or so is good to know. And then people who are, worse than 2100 are likely to not get worse. I think it's a comfort to patients to know that things are likely going to stay pretty stable for them. Absolutely. I think it's really important to enrich trials with patients who are going to have the primary endpoint that you're looking for. And so findings from this phase 2 Archer trial really did help them decide on who to include in the Archer phase 3 trial. And those results are expected later on this year. Well, I think it's something that we are accepting. The EMA really wants to see functional outcomes before they go ahead and approve any of the GA complement therapies. And so I think not only do patients care about it, regulatory agencies care about it. At the end of the day, it doesn't really matter to the patient what the anatomy is. It really matters to them whether they can see. I think we've always thought that GA was a very slow disease, and I think that as we're looking at it more, we're realizing that that vision loss and that threat of vision loss is very real and more immediate than what we would think so otherwise. And so I think earlier treatment is always helpful to help these people not lose more vision. So I think that a lot of us would be really open to having AI help analyze the images. I think being able to show a patient what their projected lesion size might be in the future, to kind of correlate that with vision, I think that would be really helpful. I mean, if a patient understands that this is what would be expected, that would probably convince them to undergo treatment a little bit sooner. And we would also see whether or not they're actually following the expected pattern for treatment response. I think that's something that we don't really have a good sense of at this point, like in the real world. And so having AI help project that would be helpful in clinical practice. I think more practically, on a research level, AI can help us identify these patients that would be good for clinical trials, because every single clinical trial is a little bit different in terms of what they're looking for and the criteria that are involved. And I think having AI look at these images rather than human graders is really going to help the research process.